Simple outline of what we'll be covering today include the principles of pediatric musculoskeletal medicine, and then moving on into the ankle injury and the leg pain. Simple principles in which to start out with when we're talking about musculoskeletal medicine includes that we want to know whether the patient is a skelly immature or skelly mature patient. The reason being is that the physis is the weak link in the skelly immature patient. They also have apophyses versus epiphyses, and for those of you that have forgotten, apophysis tends to be a site of musculotendinous insertion. It does not contribute to the length of the bone, whereas an epiphysis is a physis to a joint space and contributes to the length of the bone. When we start with the end, and that is management of the musculoskeletal injury, we start with the very basics of price: protection, rice, ice, compression, and elevation. Protection includes immobilization or lack thereof. In addition, you can consider analgesics to be a part of protection. Treating the pain is going to be very important when dealing with a musculoskeletal injury, because excessive pain around a joint will diminish the force of the muscle activation. Therefore, giving proper analgesics will be important. That does not have to come in the form of medicines, and that can simply be rest, ice, compression, and elevation, which all help with swelling and decreasing pain from swelling. And then the other portion to consider is what might be contributing to this injury. Is it overuse, overscheduling, or overspecialization? In addition, if you really enjoy sports medicine and or orthopedics, you can consider the biomechanics, the alignment, and really important in the pediatric population is mobility, including hypermobility or hypomobility. When starting with an ankle injury, there are obvious parts of the musculoskeletal history that we want to take into account. Once again, the starting point being whether this patient is skelly immature or skelly mature, because our differential will be very different as to whether they have physes open or closed. The date of onset of the injury, whether it be an acute or chronic injury, and then what is the trauma or trigger? What is the mechanism of injury? Sometimes children do need to be cued on this. You can ask, is there a trauma or trigger? You might have to ask, is there any change in the training regimen or new sport? In addition, is the pain progressive? And most importantly, you need to ask them for the point test. Where is the location of pain? Where is the point of maximal tenderness? When they want to show you all over, please ask them to say, where is the most pain? And then exaggerating and alleviating factors in addition to mechanical symptoms, whether it be swelling, locking, or instability, which generally will point to more joint pathology. In addition, if there is no obvious trauma or trigger, then you might want to delve into if there's any systemic symptoms, including fevers, chills, night sweats, any nighttime awakenings, and then for rheumatologic, morning stiffness, rashes, or oncologic considerations, weight loss. In addition, you might want to consider recent URI and pharyngitis for reactive arthritis or travel history. Moving on to further into the history, are there any proximal or distal symptoms, any prior treatment, or previous evaluation and imaging? Most importantly, when dealing with the young athlete and or patient, sometimes they cannot give the best history, and you might want to ask what activities were missed due to this pain. In addition, given that children are more likely to have hypermobility, consideration of previous subluxation or dislocations, including around the ankle or other joints in general. When considering the ankle injury, and common causes are going to be broken down by skelly immature or skelly mature. You can take a very simplistic approach to this and try and figure out the localization of the injury, whether it be bone, tendon, ligament. And looking here at a little table that I won't read fully for you, you can see the most common things, whether they be skelly immature or skelly mature. For the skelly immature about the ankle, you definitely have to consider a Salter-Harris fracture predominantly of the distal fibula in consideration of the distal tibia, or an apophyseal stress injury such as Sever's disease or Isellin's disease. Isellin's disease, for those that have not heard about that, is an apophyseal stress injury at the base of the fifth metatarsal. Moving further into the differential diagnosis of common ankle injury, in the skelly mature, you have more likely to have tendinopathy, which is a fancy term for pain within the tendon. It can be related to a tear or subluxation of that tendon, or true ligament injury or an ankle sprain, most commonly of the ATFL or the anterior talofibular ligament. We do have to consider that there might be other etiologies than musculoskeletal, such as rheumatologic and oncologic, but also know that there are nerve pathologies such as complex regional pain syndrome. When we start talking about the ankle, it's easy to divide it up into 4 quadrants: lateral, anterior, posterior, and medial. And the differential does take on different appearance for each of those locations. In the Skelly immature athlete, the most common injury is going to be a Salter-Harris fracture of the distal fibula, usually type 1, Salter-Harris type 1, but also type 2 can be seen. For lateral ankle pain in the Skelly immature patient, you should consider injury to the anterior talofibular ligament and potential other ligaments about the ankle. When talking about medial pain, the Skelly immature patient can have a multitude of things, but they are less likely. The most common things being distal tibial, Salter-Harris fracture, and accessory navicular. You can see this more commonly in the Skelly mature athlete, in which they have recurrent inversion injury and or pain in the medial aspect of the knee on the navicular that does not seem to improve with conservative management. In addition, the medial ligaments are all considered to be a broad deltoid ligament, and you may have a syndesmotic injury concurrent with that, which is another name for a high ankle injury, high ankle sprain. In the anterior ankle, the actual incidence of these injuries are less, but there are pathologies that apply to both the Skelly immature and Skelly mature athletes, most often anterior impingement or consideration of the anterior tibialis tendon. In the posterior area, some will call this ankle pain, but more often they'll complain of heel pain, and heel pain in a Skelly immature student or athlete is going to be Sever's disease or calcaneal apophysitis or apophyseal stress injury until proven otherwise. They will often complain of pain in the Achilles tendon, but if you really go down to the calcaneal apophysis, that is where their greatest amount of pain will be. When we have a Skelly mature athlete, then the consideration for Achilles tendinopathy is much more frequent. There are surrounding anatomical structures to consider, including retrocalcaneal pre-Achilles bursa, Haglund deformity, but in our ballet dancers, possibly Oz trigonum syndrome or posterior impingement. So for the physical examination, trying to keep it very simple, you can consider the range of motion to be a very decent examination of the joint structure. Active range of motion will affect joint, and any joint pathology would be brought on by pain with range of motion or limitation in range of motion. Not all limitation in range of motion is due to joint pathology. It could simply be due to pain, but it does cue you in to consider joint pathology. And then back to where we started out before, bony tenderness to palpation. Where is the point of maximal tenderness? And then when coming to anatomy, knowing exactly where the physes and the apophyses are about the ankle. Resisted range of motion, to clump this and think about what you are testing, you're essentially testing the muscle, tendon, and its insertion on the apophysis. You are not allowing joint range of motion, but putting force through that unit. So resisted range of motion can often be tested during the neurologic examination. We had mentioned prior assessments of mobility and the contribution of hypermobility. Therefore, an anterior drawer in which you distract the joint and anteriorly draw the ankle will give you a hint as to mobility, and this is only relevant in relation to the other side. If you are very advanced in your musculoskeletal skills, you can consider subtalar motion and additional provocative maneuvers such as talar tilt for examination of the calcaneofibular ligament, external rotation stress test, and tib-fib squeeze test for possible examination for a high ankle sprain or a syndesmotic injury. So when looking at where are the points of maximal tenderness or the areas in which you should palpate on exam, starting with the x-ray of a Skelly mature ankle, it's easy to see the distal tibial physis, the distal fibular physis, and then on the lateral you'll see the calcaneal apophysis on the posterior aspect of the calcaneus and the navicular. The navicular is a cortical bone which, similar to the scaphoid of the wrist, does not receive the best blood supply. Therefore, any injury to the navicular should not be overlooked. When looking at the ankle, some will also consider the feet. On the right there, you will see the the base of the fifth metatarsal apophysis. That little flake that runs parallel to the length of the fifth metatarsal is an apophysis and not an avulsion fracture. Sometimes that can be acutely avulsed off of the base of the fifth metatarsal. However, it is a normal appearance in a skeletally immature foot. In addition, the metatarsals, while not necessarily in the ankle, are a very common injury, whether they be for fracture of the diaphysis, the middle of the bone, or at the epiphyses. What you see there on the left is an ankle mortise view in which you get to see the mortise of the talus, the bone within the ankle joint. So imaging. If you were to order images for an ankle injury in a common situation, you consider AP or anterior-posterior view, mortise view, and lateral views of the ankle. You may consider views of the foot, in which the lateral view of the foot is the same as the lateral of the ankle, but an AP and oblique if warranted by your exam or point of maximal tenderness. There are Ottawa ankle rules which have been applied to pediatrics. However, their validity has primarily been established in the adult population. But the inability to bear weight, 4 steps at the time of injury or at the time of evaluation, or simple tenderness to palpation at the malleoli should warrant ankle imaging. So we're going to step into some cases to kind of go through the differential and common ankle injuries. We have a 10-year-old female gymnast with anterior and lateral ankle pain. She's in the gym 15 hours per week. She is a dedicated gymnast. She had an insidious onset and progressive pain over the past 6 months, and it's worse with landing short, meaning that she lands with her foot in dorsiflexion and potentially her knee in front of her foot. The physical exam, she has pain with passive dorsiflexion laterally. She also has pain with resisted dorsiflexion. She has an anterior drawer that's 2+, with her opposite side being 1+, and she has positive Beighton's criteria. For those who don't know these are the assessment for hypermobility, in which there are 9 criteria, 4 of which are bilateral. The first being the ability to bring the thumb to the forearm. The second being the fifth metacarpal joint to 90 degrees, and then recurvatum at the elbows of 10 degrees and recurvatum at the knees at 9 degrees. Each of those are bilateral in your first 8 points. The 9th point is for the ability to place the palms flat on the ground with knees extended. And then she also has pain with a heel walk. Her imaging is negative. She has a very skeletally immature ankle, and her diagnosis is purely driven by clinical examination. She has anterior tibial pain by resisted motion. She has anterior lateral impingement by pain with passive dorsiflexion or pain in the anterior lateral gutter. And most likely her underlying contributions are her hypermobility, her positive Beighton's criteria, and overuse, the simple fact that she's in the gym for 15 hours per week. The management for her follows very similar to the principles of musculoskeletal pain management, and that is avoidance of things that make her more painful, cross-training. She is free to do anything that does not lead to further pain, icing, physical therapy for strengthening across the joint and stabilization, and the addition of analgesics if not adequately controlled with ice and relative rest. Case number 2, very similar, but older, 16-year-old female gymnast with anterior ankle pain. So now we have a skeletally mature athlete. She's also in the gym 15 or 18 hours per week. She has an insidious onset and progressive pain over the past 6 months, same, worse with landing short, but better in her heels, and she has swelling after each practice. She also has pain with walking. On her physical exam, she has pain with weight bearing, and when you strike her heel, she states that that recreates her exact same pain. She does have tenderness to palpation over the anterior talus with dorsiflexion, and on imaging, you see something like this. On the left, you see her AP view, and on the right, a mortise view, in which you see this very subtle subchondral lucency. And this is an osteochondritis dissecans lesion of the talar dome. After the knee, the talar dome is the most likely, most common location for osteochondritis dissecans. For those of you who do not know what osteochondritis dissecans is, you can consider it a subchondral fracture in which it might be due to repetitive overload and at risk of chondral health or overlying cartilage health. Osteochondritis dissecans in whatever joint is the most common etiology of loose bodies outside of acute trauma of the joints in the pediatric population. Case number 2, this continuing on, she does have a talar dome OCD or osteochondritis dissecans, the anterior lateral dome, talar dome. Her management will be non-weight bearing until pain-free and referral to a sports medicine and orthopedic specialist. Coming back to management, once again, if you are unaware or unsure of how to treat any condition, no specialist will ever find fault with protection in a non-weight bearing state. Case number 3, a 12-year-old male soccer player with an acute on chronic lateral ankle pain. For those of you who also know Sever's disease, Skelly immature athlete with heel pain is Sever's disease until proven otherwise. However, this athlete really has chronic lateral ankle pain. The history for him is an inversion injury with an inability to bear weight with underlying chronic pain in his ankle. But he has this pain both in the lateral aspect of his ankle and slightly anteriorly. On physical exam, he is positive with tenderness to palpation on the ATFL. He has an increased anterior drawer of 1+ in comparison to his other side, but also decreased subtalar motion. This is simply a shucking of the calcaneus and talus to see if there is motion, and once again, this is in comparison to the other side. His imaging shows what appears to be beaking of the calcaneus in relation to the navicular. If you focus your attention right there, there's not a clear joint between those two bones and would make one consider a tarsal coalition. Now, the call for this talk was on common causes, and this is not necessarily a common cause, but it is something to consider, and it is common in the setting of a problem ankle or chronic pain. So it is something that should be considered in your differential. So his diagnosis is a tarsal coalition, or rather lack of adequate separation between bones within the feet. This is a calcaneonavicular. It can also be navicular talar. And these are defects of separation, whether they be a bony union or a fibrous union. The management, once again, comes back to where we started: protection, rest, ice, compression, and elevation for an acute management, and referral for further management, whether it be conservative or surgical. There is no problem with trying to initially manage these patients conservatively. Case number 4, 10-year-old male soccer player with acute lateral pain. This soccer player describes an inversion injury and an inability to continue playing. He had to remove himself from the game, and then improving pain, but still pain with walking as he comes into your clinic. He has tenderness to palpation over that distal fibular physis, and imaging for him is normal, except that he has a Skelly immature ankle. When you look closely, he does have soft tissue swelling over the lateral malleolus. This could be read as a normal ankle X-ray in a Skelly immature patient, but in the setting of trauma and tenderness in a physis, that is a Salter-Harris type 1 fracture until proven otherwise. Yes, this patient is Skelly immature, and they may point to their anterior talofibular ligament, but once again, the ligaments are much stronger than the physis, and you need to go to the adjoining physes and palpate for the correct diagnosis. As I said, Salter-Harris type 1 fracture of the distal fibula, and management could be cast immobilization. Really less important that it be cast and immobilization. The level of immobilization would be driven by the amount of symptomatology. Moving on to the uncommon causes of leg pain. Mixed within here will be common causes of leg pain, and hitting on a couple of the differentials, things to consider when seeing a young patient with leg pain. Again, the history looks very similar to the ankle pain, whether they're Skelly immature or Skelly mature, so that you are acutely aware of whether they have physes open or they are closed. The date of onset and injury, whether it's an acute or chronic, whether there is any obvious trauma or trigger, and if the pain is progressive. Again, you want to come back to where is the point of maximal tenderness. Diffuse pain about the legs makes me feel more comfortable for any lack of focal finding and think more systemically. Are there any exaggerated or alleviating factors, and are there any mechanical symptoms focal to one of the joints? In addition, because we're talking about the entire leg pain, there can be the addition of snapping of tendons over bony prominences. If you have non-focal findings, non-traumatic, again, think of systemic symptoms. If there's been any previous treatment, evaluation, or imaging. And again, if there's one question you should ask, what has this pain kept the patient from doing that they desire to do? Again, in the leg, consideration of hypermobility. If they are systemically hypermobile, you can think of that as loss of, or correction, extra stress to each of the joints and all their dynamic stabilizers. Therefore, they may overuse tendons in order to obtain joint stability. In addition, you can have subluxation and dislocations, primarily of the patella. The differential, again in the leg, is broken down by location. You can think of the joints with the knee joint being the most common, both Skelly immature and Skelly mature, for patellofemoral pain syndrome. Those that want to know what is the minimum for a correct diagnosis, it is simply anything that is referable to the patellofemoral articulation, whether it be a positive patellar grind or pain of the patellar facets, along with an etiology including increased lateral forces or weakness on the medial stabilizers. The more common things when we talk about bones, apophyseal injuries being Osgood-Schlatter's, and then also Syndig-Larsen-Johansson syndrome. Again, this is another, for those of you who have not seen Syndig-Larsen-Johansson, it is one of those conditions that has seen you and you have not seen it, but there is an additional apophysis at the inferior pole of the patella. So if they have tenderness in the patellar tendon in a Skelly immature athlete, go up to the inferior pole of the patella if you are assured that it's not at the tibial tubercle, and most likely that's where their pain will be maximal. Additionally, in the Skelly immature, you have to consider physeal fractures, Salter-Harris fracture about the distal femur or around the ankle, as we've previously discussed. In the Skelly mature athlete, you have to consider medial tibial stress syndrome, which is our fancy term for what some will label as shin splints. Differential continuing down into the soft tissues, tendons, more likely to be tendinopathy, similar to what we discussed earlier. The tendons and ligaments are weaker than the bones in the Skelly mature patient. And then a knee sprain, of most commonly of the medial collateral ligament and sometimes of the anterior cruciate ligament. One thing that looks new here is entrapments of the nerves about the lower extremities, and then the non-musculoskeletal considerations of rheumatology, oncology, and infectious disease need to be a little more in your differential for leg pain. Going back here, for those that do not know my abbreviation of CRMO, that's chronic recurrent multifocal osteomyelitis, and that is what some used to call Brody's abscesses or subacute osteomyelitis. Going by the type of injury when talking about lower extremity pains, in trauma, sprains, strains, fractures, dislocations, one must also think about non-accidental trauma for infectious, septic arthritis, osteomyelitis, and again, CRMO. Immune-mediated, you think about toxic synovitis or transient synovitis. Many use those terms as synonyms. Juvenile idiopathic arthritis or reactive arthritis. In there, you would also consider osteoid osteoma. Acquired conditions, most often going to be in your Skelly immature, a slip capital femoral epiphysis, or laid calf Perthes disease. You do not forget about neoplastic and referred pain from discitis or a psoas abscess, something related to the spinal area radiating down into the lower extremities. And then growing pains, or also known as benign lower extremity pains of childhood. There are things where parents will interpret as leg pain solely because someone has a limp or a non-painful abnormal gait. This, you do have to think about your congenital developmental dysplasia of the hip that was missed, in addition to leg length discrepancy, scoliosis, and then certain neurologic conditions such as cerebral palsy, myelomeningocele, or other neuromuscular conditions. So the physical exam, very similar to the ankle, starting with a neurologic exam of the entire lower extremities, and then focusing on each of the joints, with ankle being left out for this part of the presentation. Hip range of motion, resisted range of motion, and provocative maneuvers. Femur, predominantly around tenderness of palpation. Knee, same as any other joint, range of motion, resisted range of motion. Breaking it down into a patellar examination, a ligamentous examination, and a meniscal exam. And then same as the femur with tibia and fibula, tenderness to palpation. And consider your functional tests. These are what we do in pediatrics, is observation. How does that child single leg hop? How do they squat and pick up? How do they climb into the chair or onto the table? And if they're old enough to do a duck walk. All those things require a certain amount of strength and lack of pain to do in a fluid motion. Imaging, if you're going to image the lower extremity, these are the views that we would recommend. When you have hip pain, consider getting a AP, anterior, posterior, and frog lateral of the pelvis. Therefore, you have a comparison already built in. Those that are concerned about the radiation, that is understood, but making a proper diagnosis rather than obtaining additional images will take you much further in solving lower extremity pain. AP and lateral, both the femur and tib-fib. And then when talking about a knee, consideration of AP, anterior, posterior, lateral. And then notch and tunnel are similar names for similar views, or sunrise or merchant views. Sunrise merchant views is more of an axial view of the patella. Therefore, you can see the patellar femoral joint or articulation. The notch and tunnel view is more specific for seeing the posterior aspects of the condyles and where you're more likely to have a knee osteochondritis dissecans. If the pain is referable to the hip, consider a hip ultrasound for fluid levels, whether they are skeletally mature or immature. And if the pain is very non-focal and you are uncertain as to whether this is within the lower extremities or potentially spinal, you can consider a bone scan, given that you will have any areas of increased bone turnover. Just to know that bone scan is very sensitive, but not very specific. Many things can lead to increased bone turnover. And then finally, you can consider advanced imaging in the form of an MRI or a CT scan. When the image is a question that we commonly get, indications would be an acute injury or a chronic overuse. What defines chronic? That is a personal choice, but really any consistent pain that's greater than 6 months should be considered for imaging. And then you do not have to get imaging in the lower extremities for minimal debility, someone that is still participating in their sports and their activities, or if it's classic Osgood-Schlatter's disease or Sever's. There is, with knowledge, the ability to hold off on imaging initially. With unusual causes of leg pain, you can consider laboratory studies. The one thing to know that these are sensitive but not specific, similar to your bone scan. And the indications would be if you have systemic or non-focal complaints. You can consider a CBC with differential, looking both at the white blood cell count and hemoglobin for anemia of chronic inflammation or chronic disease, as it was once called. An ESR or a SED rate, in addition to a C-reactive protein, and consideration of an ANA. Some may ask why rheumatoid factor is in there, and that is because juvenile idiopathic arthritis is positive for rheumatoid factor only 5 to 10% of the time. Second tier consideration is going to be based on the clinical history, but blood culture, anti-streptolysin and anti-DNase B test, vitamin D level, gonorrhea and chlamydia nucleic acid amplification test, and possibly Lyme serology with a Western blot. If you have a joint that does have a significant amount of fluid, consider getting that to a specialist in which you can get joint fluid analysis or obtain that yourself in clinic. Now moving on to the cases within leg pain. We have a 14-year-old male basketball player with shin pain. The history, there's no obvious trauma or trigger, including increase in level of his play or anticipation of upcoming playoffs. There is progressive pain that's located in the mid, anterior, and medial tibia, and this pain awakens him at night. It is better when he takes NSAIDs. On examination, he does have some tenderness to palpation of the mid-posterior medial tibia with a negative single-legged hop and negative fulcrum. The imaging is the x-ray that you see here on the left with cortical thickening and a question of lucency within the cortex. This is an osteoid osteoma, or some will describe it as a target lesion if it has its classic textbook appearance. But on CT scan, you essentially see more clearly defined what is visible on the x-ray, that being a lucency within the cortex of the tibia. So he has an osteoid osteoma. While this sounds like a tumor, this is a benign bony lesion and cortical in nature. However, sometimes this leads to pain that does require surgical intervention. The management, if with minor disability and non-progressive pain, can be observation. However, with disability and or progressive pain, consideration or referral for sclerosing or other treatment to take away the pain generator. Moving on to an 8-year-old Skelly immature male hockey player who has chronic lower extremity pains. When you get his history, he describes nighttime pains that have been diagnosed as growing pains. These have been progressive over the past 3 years, and they're definitely worse after an increase in sports, and now it is bothering him throughout the day. He's had some missed games and practices due to this pain, but he denies any myalgias, pain within the muscle, or arthralgias, pain within a specific joint. On physical exam, he has no tenderness palpation of any of the lower extremities. He has full range of motion, but a review of his growth chart does show a decrease in his weight velocity. When you get imaging, he has negative 2 views of the bilateral femurs and tibia and fibulas. He has no osteoid osteoma or periosteal reaction. And this is someone where you would think more systemically, and his diagnosis on blood testing was leukemia and therefore requiring referral. Know that in leukemia, 10% of all leukemic presentations include musculoskeletal pain without an obvious etiology. This is why you follow your growing pains, or your patients labeled as growing pains on a yearly basis. Moving on to the next case, we have a 16-year-old Skelly mature female runner with lower leg pain that is located in the distal knee. Her history describes an insidious onset, but it has gotten worse 4 weeks into the cross-country season. It has been progressive, and initially it was noted only after a run to during a run, and now pain with any ambulation. She runs about 30 miles a week, and she's had 4 menses in the past year, which actually correspond with her summer decrease in her training. She follows a vegan diet out of health, and she does have a history of metatarsal stress fractures. On examination, she has tenderness to palpation of the posterior medial and anterior tibia, about 3 inches distal to the joint line. And she does have pain when you strike her heel and pain with a single-legged hop. When you get her x-ray, you see this very faint band of sclerosis within the tibia. In this setting, this is a tibial stress fracture. It could be a tibial stress reaction in which we have a negative x-ray. It could be a tibial stress fracture in which we have a negative x-ray. An x-ray will not always show you stress reaction to a bone when it is a chronic submaximal load to the bone. In essence, she overloaded her bone without adequate recovery and led to a stress fracture. So she has a tibial stress fracture with the female athletic triad, something to consider in all adolescent and driven, committed athletes. It does not have to be only female athletes, in which you have insufficient calories for level of work, disordered menses, and disordered bone health. Many may consider the female athletic triad as an eating disordered, amenorrhea, and osteoporosis, but it is now on a continuum. You do not have to have all 3 components to be concerned about the female athletic triad, but it all arises from insufficient calories for the level of athletic activity or physical activity that they are doing. The management for her would be starting with making her non-weight bearing to decrease her pain, and then consideration of a pneumatic walking boot. This has been proven to return to play or healing in a slightly faster way. She is cleared for all pain-free cross-training. The reason for that being, if we immobilize and allow her to become weaker, in her lower extremities and lose her aerobic conditioning, upon return to sport, she most likely will be a little aggressive and just run into the same risk with increased stress to that bone due to muscular weakness. Consideration of referral to a sports medicine specialist is per your desires. Moving on to the next case, a 17-year-old male runner with lower leg pain on the anterior shin. When talking about unusual causes of leg pain, this does open a differential in which you should consider in most of your runners with lower extremity pains. His history includes an insidious onset, but worse with new strength training and a summer running camps. His pain is progressive. It comes about 10 miles into the run, and if he pushes through the pain, he does start to get paresthesias, which he describes around his foot. He also runs 30 miles a week, and he has no history of stress fractures. On his exam, you palpate everywhere looking for a stress fracture, and there's no tenderness to palpation. There's no pain with a heel strike, and there's no pain with a single-legged hop. You obtain imaging, and this is a normal tib-fib series without any periosteal reaction or sclerosis. Now, as I said, your differential will include this stress fracture. It may include medial tibial stress syndrome, but usually medial tibial stress syndrome is not progressive, as you see here, and is diffuse, not pointed to in one area by history. You have to consider his diagnosis, and that is chronic exertional compartment syndrome. The keys here in the history are that it came reliably a certain amount into the run, and that it was progressive the longer he ran. For those that do not know what chronic exertional compartment syndrome is, it is not an acute compartment syndrome, which is an emergency, but rather increase in the compartment pressures with increasing physical activity. The compartments, or the lower extremity, contains 4 different compartments that are tightly bound by the skin and fascia between the tibia and the fibula, including the anterior, the lateral, the superficial posterior, and the deep posterior compartments. In a dedicated runner, and potentially because of the additional strength training, there is increased muscle mass within those compartments coupled with a training load and swelling that leads to progressive ischemia and/or paresthesias. You do need to note that any changes in the vascularity or nerves, including paresthesias, is a sign of pretty advanced compartment syndrome, exertional compartment syndrome. And for this patient, you would refer them for compartment testing in which the pressures within each of those compartments are measured, both pre-exercise and post-exercise, and this may be considered for a fasciotomy. Part of the differential, which hasn't been discussed yet, is something also called popliteal artery entrapment. Differential of lower leg pain in a runner and/or athlete includes medial tibial stress syndrome, shin splints, stress fracture or stress reaction, chronic exertional compartment syndrome, and popliteal artery entrapment, in which accessory muscles may close off the arterial blood flow under exertion. It may be a vascular abnormality that is also leading to compression of the artery. So the differential for leg pain is something to keep in mind in all your runners or dedicated athletes.